All right, welcome to our explainer. Today we're diving into a really serious topic, esophageal cancer. We're going to break down what it is, what the risks are, the kinds of signs to be aware of, and the realities of treatment. So, let's get right into it. So, our source kicks things off with this incredibly blunt clinical summary. And it really paints a picture of the classic patient profile. You've got an older man, a smoker, a drinker. He's described as cachectic, which means he's suffering from severe weight and muscle loss, and he has progressive dysphagia. That's a fancy way of saying it's getting harder and harder for him to swallow. I mean, that one sentence, it tells you almost the whole story, and it's really the key to unpacking this entire disease. So, to really wrap our heads around this, we've got to start with the absolute basics. What exactly is esophageal cancer, and where does it actually show up? At its heart, esophageal cancer is a malignant tumor that grows in the esophagus. You know, that tube that carries food from your throat down to your stomach. And these tumors aren't all the same. Some of them grow deep into the wall of the esophagus. Others are more like an open sore. And some can even grow outward into this mass that looks a lot like a piece of cauliflower. But here's the thing. This cancer isn't just one single entity. It really comes in two main flavors. And the biggest difference between them is just location. You've got squamous cell carcinoma, which usually pops up in the upper 2/3 of the esophagus. Then there's adenocarcinoma, which you'll find way down at the bottom, and it often grows out of a precancerous condition called Barrett's esophagus. And why does that distinction matter so much? Well, because the numbers have actually flipped over time. While both are obviously very serious, adenocarcinoma, the one down in the lower esophagus, now makes up about 60% of all cases. It's the one doctors are seeing most often these days. Okay, so that leads to the big question, right? What actually causes this to happen? Let's take a look at the triggers and the major risk factors. You know, the big takeaway here is that this cancer very rarely just appears out of thin air. When you look at this list, you start to see a pattern. It's almost always connected to some kind of long-term irritation or damage. Whether it's from things like smoking and drinking or from internal issues like the chronic acid reflux that causes Barrett's esophagus, the theme is the same. Persistent damage over a long period of time is what sets the stage. All right, we get the risks, but how do you even know something's wrong? This brings us to a really critical part of this whole thing. The warning signs, and just as important, how this cancer starts to spread once it gets a foothold. The number one, most common and most alarming symptom is that difficulty swallowing we talked about at the beginning. That's dysphagia. And it doesn't just happen overnight. It starts small, maybe having a little trouble with solid foods. But as that tumor grows, it starts to get hard to swallow liquids. And in the final, most advanced stages, it can get so bad that a person can't even swallow their own saliva. And beyond just the swallowing, a whole host of other warning signs can pop up, and they all tell a story about a system that's in real trouble. You see things directly related to that blockage, like regurgitation or even too much saliva. Then you get the full body effects, like that extreme weight loss we mentioned, cachexia. The tumor can even grow and press on nerves, which can change someone's voice, or it can cause food to go down the wrong pipe, leading to dangerous chest infections. And the real danger isn't just the tumor itself, it's how it travels. It has 4 main escape routes. The absolute most dangerous is direct spread. That's where the tumor literally invades crucial things right next to it, like your windpipe or your aorta. It also spreads really early through the lymphatic system to lymph nodes all over. Spreading through the blood is a little less common and happens later, but it can hit the liver and lungs. So, with all these symptoms, how do doctors actually confirm what's going on? Well, it all comes down to a few key diagnostic tools. The number one way to know for sure is actually pretty direct. It's called an esophagoscopy. They take a thin tube with a tiny camera on it, go down the throat, and just take a look. And while they're in there, they take a biopsy, a tiny piece of tissue, and that's what gets looked at under a microscope to give the final definitive answer. But that's not the only tool in the toolbox. There's also this really interesting imaging test called a barium swallow. You drink this chalky liquid and it coats the inside of your esophagus so it shows up really clearly on an X-ray. It's a great way to see any strange shapes or blockages. And this is where we get another one of those medical terms that's just so descriptive. When there's a tumor, the esophagus often narrows down to this very specific shape on the X-ray, and doctors literally call it a rat tail appearance. It's a huge red flag that points directly to a tumor. So once the cancer is confirmed, the next big question is, how far has it gone? This is called staging, and it's basically a detective process. They use different tools to get different clues. An endoluminal ultrasound, for instance, can see how deep the tumor has grown into the wall, while CT scans are looking outward to see if it's spread to the chest or abdomen. And that brings us finally to treatment. And honestly, this is where we have to talk about some of the tough realities of this disease. And here it is. This is the really sobering fact. Because those early signs can be so easy to miss, by the time many people get diagnosed, the cancer has already progressed too far for surgery to be a cure. And that one fact pretty much shapes the entire approach to how this is treated. Now, for that small group of patients who do catch it early enough, surgery is an option. The main procedure is a transhiatal total esophagectomy, which is a major operation where the esophagus is removed and the digestive tract is basically rebuilt, usually by pulling the stomach up into the chest to connect it to the throat. So for most people, the goal shifts from trying to cure the cancer to something called palliative care, which is all about improving quality of life. A lot of the time, the main goal is simply to make it possible for the person to eat again. That might mean a bypass surgery or just inserting a tube, a stent, to prop the esophagus open. Other things like radiation and chemo aren't really trying for a cure at this stage. They're trying to shrink the tumor just enough to relieve some of those awful symptoms. And that kind of leaves us with one last, really important question to think about. If this cancer is so often found late, when the options are already so limited, it really forces you to look all the way back to the beginning. If the warning signs are that subtle, then maybe our greatest power isn't in the treatment, but in understanding and actually dealing with the risks in the first place. It's definitely something to think about. Thanks for sticking with us for this one.
Welcome to the Deep Dive. We are taking a sharp focus today, really digging into a stack of sources all centered on esophageal carcinoma. This is a condition where the clinical picture is pretty starkly defined, and our goal is to sort of move past the textbook summary, to really grasp the specific details that drives diagnosis and prognosis.
Yeah, and it's essential we do that. Because while lots of cancers can have a subtle onset, the sources here, they really lay out a very distinct and often quite late-stage progression.
Right. So our mission is to break down that specific clinical profile, map out the underlying causes, understand those, frankly, terrifying pathways of spread, and look at current treatment thinking. We start with that classic image presented, don't we?
Yeah.
The sources describe like an old, severely wasted male.
Eclectic, yeah.
Eclectic, right?
Yeah.
Often a history of heavy smoking, alcohol use, presenting with that progressively worsening difficulty swallowing, dysphagia.
That classic picture, it's a critical starting point. But I really want to stress to you, the listener, that while that profile is memorable, understanding the underlying factors is the real key, for prevention, for early diagnosis. Not everyone fits that specific archetype anymore. The epidemiology is definitely shifting.
Okay, yeah, let's unpack those factors then, because understanding the causes, it helps us see why the location of the tumor seems to be changing too. Historically, it was all about chronic irritation, wasn't it?
That's right. For decades, the classic culprits linked to that damage were, well, the sources list spicy foods, smoking, and spirit, meaning heavy alcohol use. It's that repeated sort of low-level chemical irritation. Damages the esophageal lining, leads to cellular changes over years, dysplasia.
But the big shift, the real game changer in the modern picture seems to be this Barrett's connection.
It absolutely is. Barrett's esophagus, it's a crucial premalignant condition, often a complication of severe, long-standing GERD, gastroesophageal reflux disease. Acid just repeatedly damages that lower esophageal lining, and the cells, they actually change. They start to look more like intestinal cells.
Okay, so we've got sort of two main pathways emerging, the classic irritation one and this acid reflux-driven pathway. Are there other structural things the sources mention, like Other risk factors?
Yeah, a few. Basically anything causing chronic pooling or obstruction. The sources list achalasia, especially if it's been there a long time. Post-corrosive strictures, from swallowing chemicals. And even certain benign tumors like papillomas or adenomas. It's all about that chronic insult leading to chronic damage.
And speaking of where the damage occurs, the site of the tumor itself seems to tell a story, doesn't it? It points towards which pathway was likely involved. Seems the location has kind of migrated downwards.
It really has. Historically, yeah, tumors might have been more spread out or maybe concentrated higher up middle and upper thirds, reflecting that smoking and alcohol damage. But the sources absolutely confirm this major modern shift. The lower third of the esophagus is now the most common spot for cancer.
Right. And if the tumor's in the lower third, we should immediately be thinking adenocarcinoma, shouldn't we?
Yeah.
Because that location shift is directly tied to the rise in Barrett's and acid reflux. Is that the right takeaway?
That's precisely it. The acid reflux hits lower down, leads to Barrett's right there, making that lower third the new hot spot. And this shift, it leads us perfectly into the pathology.
Okay, let's talk types then. You mentioned squamous cell and adenocarcinoma. Is that division always super clean?
It's largely pretty clean, which helps, for thinking about it. You've got squamous cell carcinoma making up maybe 40% of cases, generally found in the upper two-thirds. That's your classic alcohol smoking-linked cancer.
Yeah, and the one that's increasing.
That would be adenocarcinoma. Now accounts for, about 60% of cases? And it's almost exclusively found right down in the lower 3 centimeters of the esophagus, that very specific junction, because, like you said, it arises right on top of that damaged Barrett's tissue. So yeah, location is highly suggestive.
That distinction, upper two-thirds versus the lower 3 centimeters, that's a really good way for you, the listener, to kind of categorize these two main types. Before we get into spread, anything on how these actually look, like visually?
Yeah, the sources mention the macroscopic appearance. Regardless of cell type, they tend to look one of 3 ways to the naked eye, like an infiltrating mass sort of spreading within the wall, or an ulcerative mass like a crater, or sometimes a bulky cauliflower mass growing into the lumen.
Okay, now the scary part, spread. Knowing where it starts tells us where it might go. The sources break spread down into 4 ways, right? And the first one, direct spread, is called out as the most immediately dangerous. Why is that?
It is the most dangerous, mainly because the esophagus doesn't have that protective outer layer, the serosa, that most of the gut has. It sits kind of exposed next to really vital organs. So direct spread means it's invading, like right into the trachea or bronchus, or the recurrent laryngeal nerve, the RLN, the lungs, the pleura, or crucially the aorta.
Wow. The thought of direct spread to the aorta is just catastrophic potential right there.
It changes everything instantly. And like you mentioned, hitting the recurrent laryngeal nerve, the RLN, while maybe not immediately fatal, it's an incredibly serious sign. It means the tumor is advanced, it's breached the esophageal wall.
Okay. And what about lymphatic spread? That often happens earlier, I gather. It seems very site-specific, almost like following a drainage map.
It is. It's a very logical map. If the tumor is high up in the cervical esophagus, the neck area, it spreads to the deep cervical lymph nodes there. If it's in the thoracic esophagus, the chest part, it goes to the mediastinal nodes. And if it's down low in the abdominal esophagus, it drains to the celiac lymph nodes. Makes sense anatomically.
Yeah, that follows. But here's a detail that really jumped out at me from the sources, this rare but very specific transcolomic spread.
Ah, yes. That's the ultimate specific detail, isn't it? That happens when cancer cells sort of flake off into the abdominal cavity and travel across that space, the peritoneum. And crucially, this only happens if the tumor involves the abdominal part of the esophagus. The most memorable example they give, though it's rare, is spread to the ovaries. Presents as a Krukenberg tumor.
A really unique pathway. Okay, and blood spread, is that a big concern?
Thankfully, no, not usually. It's rare and typically happens very late in the game. If it does happen, the blood-borne cells mostly end up in the liver and the lung.
Right. Let's shift then to the clinical picture. Because the symptoms, while classic, they really point to a rapid, severe decline. That hallmark is the progressive dysphagia.
And progressive is definitely the key word there. It starts with trouble swallowing solids, then quickly moves to fluids. But the real turning point, often meaning it's quite advanced, is when the patient eventually can't even swallow their own saliva. Leads to that continuous dribbling.
That inability to manage saliva, that must be a devastating sign both for the patient and the clinician. Just indicates complete obstruction.
It really is. And that severe obstruction, it causes other big problems too, like regurgitation. which, if it's blood-stained, that's another bad sign. And the regurgitation often leads to lung issues, aspiration pneumonia, repeated chest infections. Combine that with the generalized cancer cachexia, that's severe weight loss, loss of appetite, and you really see the full picture of decline.
And those signs of infiltration we talked about earlier, like involvement of the RLN,
Yeah.
how does that show up physically? What are clinicians looking for?
Well, they're definitely looking for signs of spread or local invasion. A change of voice, for example, hoarseness.
Yeah.
That's a huge red flag. It strongly suggests the recurrent laryngeal nerve has been hit by the tumor.
And in terms of general signs versus local ones?
General signs are the usual suspects, unfortunately. Cachexia, dehydration, maybe signs of that secondary chest infection. Locally, though, there are a couple of key things to look for. In the neck, feeling for enlarged lymph nodes, specifically Virchow's node, that's the one in the supraclavicular fossa, indicating metastatic spread upwards.
Virchow's node, the sentinel node. That's a key term for you listening. Immediately suggests distant metastasis.
Precisely. And then in the abdomen, they're feeling for metastasis in the liver, maybe a hard nodular liver and potentially malignant ascite fluid buildup. These are pretty clear signs the cancer has spread beyond the local area.
So, okay, you've got a strong clinical suspicion based on all this. What's the definitive tool? How do you actually lock in the diagnosis?
The gold standard, the definitive tool, is esophagoscopy and biopsy. You absolutely have to get in there with a scope, look directly at the tumor, assess its size, how juice it seems to go, and most importantly, take tissue samples biopsies to confirm the exact cell type under the microscope.
But I do find those visual markers from the barium swallow quite striking. That's often done first, isn't it? Gives that immediate picture of the blockage.
It often is, yeah. And it gives those two characteristic appearances that are really useful for quick identification. You get the rat tail appearance, where the barium stream tapers down sharply at the obstruction. And you also might see shouldering, where the tumor mass creates this abrupt, shelf-like blockage against the barium flow. Very visually distinct.
Okay, so diagnosis confirmed.
Yeah.
Then staging becomes absolutely critical, right? Because that dictates the whole treatment approach. How do clinicians combine the different tools to figure out the extent of infiltration and spread?
Yeah, staging is everything for determining operability. We use tools like endoluminal ultrasound, or EUS, that gives a really detailed look at the depth of invasion within the esophageal wall itself. How many layers has it gone through? That's crucial. Then a chest x-ray, CXR, to look for obvious lung nodules. And comprehensive CT scans neck, chest, and abdomen, looking for any distant spread, like to the liver or those lymph node groups you mentioned.
And what about checking for that dangerous direct spread into the airways?
Right. That's where bronchoscopy comes in. It's essential if there's any suspicion at all that the tumor might be invading the trachea or the bronchi, because finding that, again, it immediately changes the prognosis and the treatment options.
Which brings us to treatment. And here's where the sources paint a pretty grim picture, honestly. The symptoms usually only get bad enough for someone to seek help when the tumor is already quite advanced.
That is the sobering reality, unfortunately. The sources are clear. Most cases are actually deemed inoperable by the time they present. The symptoms only become really impossible to ignore when the obstruction is severe, which often means the cancer has already infiltrated nearby structures or metastasized.
But for those cases that are caught early enough or seen potentially operable, what's the preferred surgical approach now?
Well, the preference these days often leans towards a transhiatal total esophagectomy. It's a huge operation, really extensive, which just highlights how aggressive you need to be to even attempt a curative resection.
And outside of surgery, what about adjuvant therapy? Chemo, radiation.
Oh, absolutely. Chemotherapy and radiotherapy are used a lot. They can be particularly effective, especially for those squamous cell carcinomas, the ones typically higher up in the esophagus.
So when surgery isn't on the table, the focus shifts entirely to palliative care, doesn't it? The main goal then becomes improving quality of life, primarily by restoring their ability to swallow something.
Exactly right. It becomes about functional restoration, symptom management. Palliative options can include surgical bypass using stomach or colon tissue to create a detour around the tumor. More commonly, though, you see intubation, where a palliative stent or tube is placed through the tumor to keep the passage open. There's also laser photocoagulation to sort of burn away some tumor bulk. And radiotherapy is often quite good, especially for tumors higher up, at shrinking them enough to relieve obstruction.
And chemo still has a role, even in palliative care.
Yes, it can. Often using agents like 5-FU, that's 5-fluorouracil, it might help shrink the tumor a bit, relieve pressure, maybe slow down how quickly the dysphagia gets worse.
Wow. Okay, this has been incredibly thorough. We've really mapped out the shifting causes from those classic irritants to the huge impact of Barrett's esophagus. We've looked at the precise pathology linked to location, those dangerous spread pathways like to the RLN and aorta, and that tough reality that most cases present late.
And for you, the listener, I think being able to connect those dots, like recognizing the significance of finding Virchow's node or seeing that rat tail appearance on imaging, that's the real shortcut to understanding just how advanced this condition often is when diagnosed.
And if we pull back and connect all this to the bigger picture, especially that rising prevalence of adenocarcinoma.
Yeah, I mean, given that strong and increasing link between chronic GERD, the Barrett's esophagus it causes, and the fact that adenocarcinoma in the lower third is now the most common type, it really raises an important question, doesn't it? Considering how aggressive this cancer is once it takes hold, how much greater could the impact be if we were more proactive, more aggressive with early screening and intervention for chronic GERD itself? Could that significantly reduce the overall incidence of esophageal carcinoma down the line? That connection between something as common as reflux and this really devastating cancer, that's something powerful for you to think about and maybe explore further.